Hello, everybody. Welcome to another AFR EMS case study. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today I am joined by Lieutenant Brent Rorick. Welcome, Brent.
Thank you.
And Captain Jeff Rossetti.
Thank you, sir.
Thanks for joining us, gents. So today we're going to talk about an interesting case, an overdose case with a new substance that's actually new to us and just to EMS in general. So this call initially came in for Rescue 8 and Engine 8. You guys were dispatched to a 12 Delta. Talk with us a little bit about the information you got upon dispatch and how that compared to what you found on scene.
We were dispatched out for a 12 Delta. First call, day one, for a 12 Delta in a pretty close apartment complex. We had some ideas of who it may be, if it was a regular patient or not. But then we saw that it was for a 22-year-old male, and nothing rang a bell, anything along those lines. We arrived on scene. It's pretty close to the station. Arrived on scene is multi-story, multi-family residence, second floor. Made our way up the stairs. I actually brought my Versed with me because typically when these apartments are so deep, I'll bring it with me and go from there. And so as we came up, you could see the male laying down right at the doorway, full tonic-clonic activity, true seizure call. I already started pulling up the Versed. I pulled the full 10. We administered the first 5 milligrams, didn't touch it whatsoever. And you could tell that that first 5 wasn't going to do anything. Had the second 5 hit him with that, maybe slowed down the seizure-like activity, but nothing to write home about. We tried to get a secondary about what exactly had been going on. Didn't have a seizure history, didn't have anything along those lines. And the caller, she was there. It was his significant other. She said, we're like, does he have a seizure history? No. Did he used to use drugs? Anything along those lines? And she admitted that he used to use opiates, but he's in remission and he's been using Kratom. And she said so matter-of-factly that we were supposed to know exactly what she was talking about, and we had no clue whatsoever. And she educated us, and she said that, Kratom's just, you can get at any smoke shop in Albuquerque. It's over the counter. You can get at smoke shops or gas stations. And I mean, it's been over 20 years since I've been in a smoke shop. I hadn't heard of it, anything along those lines, didn't know what the effects of it were, and went from there. It doesn't change the fact that he was seizing in front of us. We're up a flight of stairs, so we had to address that by time ambulance showed up. The 10 milligrams of Versed kind of broke the tonic-clonic activity enough to put him on a patient mover. We had suctioned out a lot of secretions, got a baseline set of vitals-ish, and got him down the stairs. Still seizing a little bit. We're oxygenating him with an on-rebreather, got him down to the gurney, got him out to the ambulance, went for a reassessment, and found that he was satting like 94%, nothing bad on 10 or 15 liters non-rebreather, but his heart rate was 40, 48, and decelerating. So we threw him on the monitor, threw him on the pads, thought we were going to be able to pace him because there was enough that we could pace, or at least we thought we were going to be able to grab that and bring that back up. However, he went into PEA, asystole algorithm. We started compressions. My partner was able to get the Lucas because we're already in the back of 5.5. It was time to transport. And I was kind of thinking that we were going to be okay, that now we're just working a bradycardia. We're going to be able to pull that out, but then he went pulseless. She threw the Lucas in the back. We're able to set him up on that. 1 round or 2 rounds with the Lucas was fine. Then a rhythm check, we found that we're in VTAC. We defibrillated, continued with compressions, did epi, lido. I don't think that we moved on further than that, because then he would go into this PEA, asystole algorithm, kind of going back and forth. We secured the airway with a size 3 or 4 LMA, and we're able to go from there. And there was a couple different times where he went from VTAC to PEA, back to VTAC. We may have shocked him 2, maybe 3 times, but then he would change algorithms from there. All the way until we got to the hospital. It looked like another shockable rhythm. It was a wide, bizarre, complex. Wasn't really accelerated though, but it was a wide, bizarre, complex. We had pulses on this. And so we held off on a defibrillation. We're literally in the parking lot of UNM, and we did have pulses. I think that was a sine wave. I think he was hyperkalemic at that point, but later on, toxicology revealed that he was actually hypo. Okay. But we're there with pulses. There really wasn't anything that we could synchronize on that. And so we just decided to go into the recess room where everybody was there. They did maintain pulses after another rearrest. He rearrested again. I think that they defibrillated in hospital. And they were talking about cannulating him, but they ended up holding off on it.
Such a fast progression for a young patient, 22 years old. You said about 150 kilograms. That's a young person to have that extensive.
I think that's pounds, because he was skinny,
smaller.
Yeah.
Okay. So from the QA's perspective, I'm going to lean on Jeff because Cap did some extensive research. There was some items in the QA log that we started to see where there was Kratom started to appear in some of those logs. We keep a daily log for good communications on the calls that the QAs are seeing out there. And you're essentially my subject matter expert, because I know you did a lot of work and you have a training that you're preparing to go out department wide. So Cap, tell us, what is Kratom and what do we need to be looking for?
Yeah, so interestingly enough, it's actually classified as a supplement, which bypasses some FDA things, and it kind of allows for it to be sold in various ways. And a couple of those ways are smoke shops, like mentioned before. But there are also quite a few websites dedicated strictly to the sale of Kratom itself. And it's I guess a little history on it. So it's a commonly used herb or plant material in Southeast Asia. It's used a lot in the working class, and actually sheds light on kind of how strange the drug is, because for lack of a better term, we'll use it because it is illicitly used, so we'll call it a drug. So the working class in Southeast Asia will chew on the leaves. It kind of has a stimulant effect at the lower doses.
Yeah, that's what I read, was working class uses it as at the lower doses for a stimulant effect, and then the higher doses are more pain relief instead of opiate.
Exactly. So what people are doing, they're finding ways around. It's no secret that the fentanyl crisis is on the rise. A lot of opiate use with the heavy influx of fentanyl coming into the communities, and so people are looking for ways. And it's also a twofold issue where physicians are actually recognizing opiate dependency and administering these medications less frequently, and looking for other means to support pain management. And so this particular product has been used for people seeking the analgesic effect of opiates, and to kind of subvert that dependency that they're finding that they need for relief from the opiates. And so it's found in a bunch of various different ways. like in Southeast Asia, they'll chew the leaves and stuff like that, or make a tea out of it. When it's used, in an illicit setting, you can go to. I've seen it at gas stations, and kind of looking into the research of this. It's right there next to the
Stands.
diet pills and everything else that might be there available to you, and so people are just easily been able to pick this item up. The problem is it's not regulated. So it as classified as a supplement, there's no real pharmacy regulation and dosing criteria or anything like that. So you could be getting anything or of any amount. And so if people are using this, in this research, we read a lot. I read a lot of material about it, but a lot of the research, interestingly enough, was done on YouTube. There is a pretty significant drug subculture of influencers talking about drugs and or using drugs, and actually became a pretty good resource to see what was going on. And with the easy access of this, people can access and make videos and do those sort of things on it too. It's funny because a lot of these influencers start with maybe the positive aspect of what these drugs look like or what they're doing to you, and kind of highlighting the side of things that people might be looking for in positive ways. Consequently, looking back, you can kind of scroll back in time, and a lot of them found themselves doing videos of why they stopped using it. And one particular reason is, and I think what led to, a lot of the discussion based on this call, is the dependency aspect of it. So like anything else that, folks might use to wean themselves off of opiates, this is a similar mechanism. The most common alkaloid in this is called metragenine, and what that does is it actually it has an affinity for the opiate receptor site, thereby giving it the analgesic effect that people are looking for with opiates, and seeking pain management outside of the illicit realm or the prescription methods.
The opiate receptors, and what I found on that is the mu kappa delta receptors.
Getting deep.
I know nothing other than that.
So we got mu kappa delta, we got metragenine.
Yes, yeah.
So for the lowest common denominator, like me, and I respond to a call where they tell me this person used Kratom. I know it's acting on those opiate receptors, but it's not necessarily an opiate. Is that fair to say?
Fair to say, yes. So there are some similar mechanisms of action and results that people will gain from that. But because of its dynamic use spectrum, in one aspect being a stimulant, and then almost having the opposite effect of having that opiate type response, euphoria and relaxation and whatnot. The vital signs, in tracking and looking at what this looks like, various aspects, it can go from tachycardia to bradycardia. A lot of hypertension is noted in here. There's also, which lends to this case pretty well, there are studies suggesting that it can increase the QT interval pretty significantly as well. And so, management of this particular, it's going to be management of vital signs like any other. The question becomes, Narcan use and things of that nature. With the complex pharmacokinetics of this drug, we really want to tailor that Narcan specifically to people who are in respiratory depression, titrated essentially to support that and show an improvement. But there are some things that suggest that, Narcan can possibly also, cause other issues on the other end of the spectrum of this medication.
Yeah, and I was seeing a lot of the same thing. It could be hypertensive, could be hypotensive, could be tachycardic, could be bradycardic. And I have seen the studies that come out and say Narcan can be indicated because it does work on some of the opiate receptors, but you have to treat what's in front of you. If they're hypoxic, if their respiratory rate, depth, and effort is low, then maybe Narcan could be used, but sparingly, knowing the adverse reactions with it. If you give too much and now you have somebody that's totally withdrawal in front of you, throwing up all over the place, having airway compromise, things along those lines, it's something to watch out for. This was so treatment specific. I mean, we were just working on a seizure. And then he had those arrhythmias that led to VTAC, and going from there. But
yeah, treating what's in front of you, I think, is key. I think you guys did a fantastic job of that. Ultimately, in the moment the life threat was his seizure, you were treating that. Then we started to, progress into the cardiac arrhythmias, which you then treated, and that's how he coded. And then you're working with that. So I think in terms of like what you said with the opiate, if it's a known opiate, then you can treat it that way. If you have low respiratory depression, you have the pinpoint pupils, then okay. But I think thinking about it, if they're telling you specifically this individual took Kratom prior before they started seizing or went unresponsive, thinking through that pharmacokinetic swing that could happen with the opiate, probably one of the very few times to where it's not such a benign drug to be able to give the Narcan.
Correct. Definitely correct. And I think one thing to take away as well from this, just briefly, is there's not a lot of research on just Kratom as an individual compound in research. A lot of times this drug is part of a polysubstance profile that these people are taking, whether that be alcohol. They're obviously using it for fentanyl or opiate dependency, and a number of other. There's also some use for psychological reasons. So antidepressant use compounded with Kratom as well. So taking that broad approach, to changes that might occur, might not be specific just to this particular drug.
Just having this now that it's out there and it is so easily available, just having it in the back of our head that, this could be what's going on, and kind of asking those questions of any bystanders, anybody that's with them, I think is super helpful. So if I just don't know, I don't know what they took, I'm just guessing at it. What advice do you give providers in terms of how to treat a patient that took something or took a bunch of things and they just don't know what it is?
Well, we're obviously going to follow our same treatment modalities, primary assessment, assessing vitals. Obviously, we go talk a lot about how vitals are vital, and ensuring that you do, all your diagnostic testing. You want to get a BGL. These people are maybe presenting, unconscious, unknown, and then also putting them on the monitor. We've talked a little bit about, the cardiac aspect of this drug being pretty unknown. We definitely want to get a 12 lead quickly on these people, and then treat what you see. In this particular instance of the case we're talking about, this is a seizure. You also want to, you definitely want to address the seizure activity, and then provide all the supporting interventions to assess to manage the vital signs that you do see.
They did a fantastic job of treating the seizure initially, had the cardiac arrhythmias. We had a code. They worked that. Sounds like you got ROS prior to arrival. Yeah. We always have the benefit of having the follow-up from these patients after the fact. The amazing care that you guys provided in treating him perfectly, it sounds like walked out of the hospital 2 days later, totally neuro-attacked. Dr. Pruitt let the toxicologist know at the Poison Center. It sounds like they're working on a paper to get the word out about Kratom, because like you, I had never heard that before until we started having these discussions and some of its potential dangers. I reached out to our contacts with the DEA to find out if it was something that was on their radar. And currently, since it's available for legal purchase, it's not. It's just something that's kind of being monitored but not pursued. Dating myself, but going back to, I remember Spice first hit the market, right? It was available at smoke shops, and then we started to see the negative effects of that, and then it got pulled. So I assume this is probably going to follow that same path. But just goes to the point, we've talked about the opiates, we've talked about fentanyl, we talked about xylazine, now we're talking about Kratom. There's always going to be one step ahead of not only law enforcement, but emergency medical practice that we just have to adapt and overcome, because we are going to start encountering some of these drugs that don't respond to the tools that we have in our toolbox. So going back to our ABCs, treating vital signs, I think, is the only answer.
Yeah, and that's what happened with the Spice and the bath salts. You could get at any local gas station, and once there was an overdose or something along those lines, those manufactured, since they weren't FDA approved, they would just change one chemical, and they'd keep their shop going, and they were able to manufacture everything. And we saw what happened after that epidemic. So
Nothing you had in your toolbox was going to treat the underlying cause of this, but you did a fantastic job. You saved this gentleman's life with the care that you provided in an unknown situation. So fantastic job. We have about 30 seconds left. Anything else we should know about Kratom for the folks out there if they encounter?
Not necessarily. I think this just sheds a light on the fact that it does exist. It's easily obtainable. It's like anything else. You're going to have children in contact with this. I think vigilance is best in this situation. And now that we kind of know, you're looking for capsules with an unknown powder in them, green of nature, looks like a vitamin potentially. It comes in elixir form where you can drink it. I think knowledge is power in this situation. Now we know that this is a potential risk to our people. Just keep a good eye out for it and report it. So maybe we can start tracking some things with this.
Yeah, poison control and just documenting it well. And that way we keep close eyes for the folks that are looking at it. So great job. Training coming soon. I think quarterly training from the 7/8. One of them is Captain Rossetti's. He's going to do a whole training on this. So there'll be more to come with this. We'll follow it closely. But I appreciate both of you coming out here to talk about this important case. If anybody else has some interesting cases that they want to share, use our SharePoint tab, reach out to anybody in the EMS division and come and talk about it. This is the way we get the information out the easiest and in the most entertaining fashion, especially with these two gentlemen here. But until next time, thank you, everybody.
thank you.
Thank you.